I've got Martin Ansell here today, who's the consultant psychiatrist from Together, and we're doing a series of podcasts. This podcast, we're going to talk about the various people in the dementia team that are going to help GPs with looking after people with dementia out in the community. Martin, could you just start by explaining what a community dementia nurse is going to do for me as a GP potentially?
Yes, certainly, and nice to be back. What we're looking to do is we're looking to try and support people with dementia and their carers nearer to home and in their own communities as much as possible, and avoid the need for them to have lots of contact with secondary psychiatric care systems. So we are taking our trained community psychiatric nurses. We're giving them extra training both in the diagnosis of dementia and its management, and we are making them far more primary care facing. We will be linking them to individual surgeries, and so all GPs and practice nurses should know by sight their community dementia nurse. They should be knocking around the surgery on a fairly regular basis and should be easily contactable. They, of course, are clinical staff, and so they will be there available to help GPs to diagnose dementia. They will be there to assist district nurses in perhaps how to manage people with dementia. So, for example, you have somebody with dementia and a leg ulcer who is resistant to having the dressings changed. They would be able to assist with that. They would be offering post-diagnostic education or signposting to post-diagnostic education for people's carers. They would, if the GPs like, help them to manage their QOF register. What we would really like is for them to take their caseload, everybody in their GP's caseload with dementia. That way, everybody is assured, if you like, having a specialist, knowledgeable nurse who they can call upon if needs be. They would be around to offer annual reviews or to assist with annual reviews, and also perhaps to offer what we're calling short-term interventions. So this is if where the home situation is perhaps a bit shaky, a bit difficult, and the carers or the family need a bit of intensive support. They could go in quite regularly for 3 or 4 weeks to help out and then pull out again. And hopefully this would avoid the need for referral to secondary care. Obviously, if referral is needed, they're also, of course, a good gateway and pathway to move people on into specialist psychiatric services. As well as the CDNs who are clinical staff, we have people called dementia advisors, and these tend to come from voluntary sector. And again, these are people who are often knowledgeable about Alzheimer's disease, and they will have a role, if you like, as a guide or a support from diagnosis to death. They will be there to be contacted by and to contact patients and their relatives and to signpost and help out with difficult decisions. When to place in care home, how to do a lasting power of attorney, what to do if your social worker doesn't help, that sort of thing. So they're more of a signpost and advisory service. We've also been looking to increase the support we give to people with dementia living in care homes. And there are, if you like, again, 2 types of people who you need to be aware of in care homes. The first are carers within the homes who have undertaken some training, who are called dementia link workers. They've all undertaken a 9-month day release diploma course in dementia care and certainly will be knowledgeable about how to manage dementia and particularly what are called behavioural disturbances in dementia. And certainly if you're visiting people in care homes, it's always worth asking if there is a link worker you can talk to. The other team that you should know about for care homes is something called a care home support team, and they have both district and psychiatric nurses in who will go and assist care home staff in managing patients with dementia, both physically and psychiatrically, and half of their time is spent in education and half in hands-on care.
So it sounds like these are the sorts of people I could potentially include in a care plan that I was developing for a patient who's got dementia, and I'm particularly thinking about this new unplanned enhanced service care plan and who to put in there. And I think a number of these patients will turn up in our top 2%. And I think it will be, from what you're saying, really important to have some of these other people, the CDN, the dementia advisor, and potentially a dementia link worker in that care plan, just so that everyone understands how joined up our approach has to be.
Oh yes, I think certainly for people in the community, either at home or in care homes with dementia, it would be essential that at least one of these people is included within the care plan. The hope is that they will be, if you like, an integral part of the primary care team, or that's how they'll be seen within the next few years, and shouldn't be anything out of the ordinary.
Okay, thank you, Martin.
My pleasure.